Hi there. It's a great pleasure to be asked to present at this forum. My name is Andy Roche. I'm an orthopedic surgeon in London, and I'm going to be talking to you about Achilles tendinopathy, and with particular reference to the surgical perspective in dealing with athletes and elite athletes. So this is a little bit about myself, I suppose. I work in the Fortis Clinic in London and also Chelsea and Westminster Hospital. Some of you may be familiar with these. And I tried my hand at most sports over my life, and to a relatively high level in some of them. But I do think that when we're dealing with athletes and elite athletes in particular, it's important to have an understanding of what they're going through, or at least have some familiarity with the systems that are in place in performing activities at multiple levels, and having some kind of awareness of what they may well be experiencing. So for me, it's important to stay active as much as possible. I did play a lot of team sports as a younger chap, but now I spend more time cycling, playing a bit of golf, windsurfing, etc. So we're going to talk a little bit about the Achilles tendon, of course, the surgical anatomy of tendinopathies, investigations and also injections and surgery, and with reference to elite sport, what are the challenges that I face and what are the challenges that we all face when trying to manage these extremely gifted individuals. So first, to talk a little bit about the anatomy. The Achilles tendon is not a straightforward tendon, as you probably are aware. It's made up of multiple fascicles. It's made up of multiple muscle insertions from lateral medial gastroc and also soleus. And as you can see on the picture on the right, it tends to spiral as it goes from proximal to distal. And of course, there's a small muscle called the plantaris tendon, which you can see in number 3, which is on the medial side of the Achilles tendon. When you're looking at the cross-sectional anatomy of the tendon itself, each part of the tendon is generally made up of fibers from certain muscle groups. The bulk of it is, as you can imagine, is the soleus muscle, but also medial and lateral gastroc have significant portions as well. The medial gastroc having insertions on more anteriorly and also slight postural laterally. So it's an important thing to remember that when somebody has specific injuries on certain parts of the tendon, it may well be driven by one or another muscle. When you look at the insertion of the Achilles tendon onto the bone itself, each part of the insertion is generally made up by a footprint of the tendon, of course, and that part of the tendon again is driven by one or another muscle. So that's again important when you're looking at insertional pathologies as to whether they're driven by one muscle in particular. So what is the Achilles at risk? Well, we all know that the Achilles itself can have multiple causes of problems. It's definitely a sports injury. There's no doubt about that when you're talking about an Achilles tendinopathy in field sports, in impact sports, and sports we're changing our direction. As people get older, we definitely see more Achilles tendinopathies. Obviously, secondary to the intrinsic changes that the tendon goes through as somebody gets older, which you can read here. The mechanics are important, which a lot of people forget. So if somebody has got a significant flat foot or significant calcaneal valgus, for example, then that needs to be corrected if you're going to deal with the Achilles problem, because the two of them are obviously going to be related. And of course, in chronic disease, less likely and less of a problem in elite sport, of course, but in somebody who has got significant other comorbidities, that can absolutely have a cause and effect with regards to Achilles tendinopathy, particularly medications, of course, things like systemic steroids. If somebody is diabetic, if somebody has obviously an inflammatory arthropathy, which you can get in younger athletes, of course, and it can be a lifelong concern and a lifelong condition to manage. If somebody has got an inflammatory condition that might lead to predisposition to tendon issues. And of course, other things like quinolone antibiotics, in particular ciprofloxacin, which we can see causing intense reactions. So what is the problem we're dealing with? Well, it's really, a big problem that we see in a lot of runners and in particular long distance runners and endurance runners. The general population, of course, has got a percentage there. It's less than 1% of the general population, but the vast majority of these will be people in sports. We know that if you're doing field sports, you're more likely to get problems with your Achilles at some stage in your playing career, whatever that might well be. And we know that only around a third of these who are treated conservatively fail to significantly improve, therefore leading to that proportion who may be coming to see me, for example. It can be a recurrent problem in 30 to 40% of individuals, as you can all see, and if you're involved in sport yourselves, then you know that these patients can keep coming back. And you're learning to keep dealing with their mechanics, their muscle strength to really keep their tendon in good condition. And of course, it can have a significant impact on professional athletes, and it could lead them to retire from whatever sport they're playing. So where do we have the problem? Well, as you can see here, the vast majority of the issues that we see is, and you would probably agree, is in the mid portion of the Achilles tendon. So broadly speaking, we talk about non-insertional and insertional tendinopathies. We're going to expand on that a bit more, but when you're looking at non-insertional or actually insertional as well, things you need to look out for are obviously muscle wasting in the affected side. You know, with non-insertional disease, you can get a significant thickening or swelling of the tendon, and also some crepitus, especially with paratendinopathy, which can sometimes be easily missed. Of course, you need to look for a hindfoot deformity. So if somebody has got a significant calcanea valgus, then it's important to realize that these things will be related for sure. And you need to try and correct that hindfoot pathology, or indeed any other pathology in the midfoot or forefoot that might be contributing to the Achilles pain. And of course, you can compare the affected tendon to the other side, unless the player or the patient is unlucky enough to have both sides affected. When you're looking at insertional Achilles tendinopathies, we all know that there are these typical bumps at the back of the Achilles insertion, and we'll go on to talk about this a little bit later. But of course, that can be made up from skin, from bursa, from bone, from tendon, or a mixture of all of the above. So, when we're talking about the athlete, well, what exactly is the real diagnosis we're dealing with? Because if you've dealt with people with Achilles tendinopathy before, I don't think it's good enough to just give them a label of Achilles tendinopathy. We're really talking about often a very specific part of the tendon or the muscle tendon complex that is giving them a localized pain and very localized symptoms on specific activities. So we're lucky enough at Fortius to have a UTC scanning and sports medicine clinic, which is basically an ultrasound tissue characterization clinic, which are the images you can see here in front of you. And that gives us both grayscale images and also colored images to look at effectively the intrinsic fascicles of the tendon and where the problem lies. So we're looking at color schemes to determine whether there's pain in the tendon, the green and the blue, differing from the red and the black, of course, where there might be problems. And this can lead us to telling us where the issues are. So do they have a normal tendon? Do they have a tear at the insertion? Do they have a inflammatory problem around the plantaris muscle, which we'll talk about significantly? Have they got a linear tear in the tendon itself? Have they got a paratendinopathy, which is more of a circumferential, or paratendinitis, which is a circumferential inflammatory problem? Or do they have a partial tear? Or indeed, there are other things such as diffuse Achilles tendinopathy with significant swelling around the tendon, or localized fusiform tendinopathy. So there's lots of ways that we can characterize the problem in the Achilles tendon depending on the clinical features, and of course the ultrasound and even the MRI features as well. So how do they present to me? Well, if you're dealing with the elite athlete, or indeed even some of the club athletes, the amateur levels now, a lot of these patients are getting monitored by personal physios, of course, and they're having concerns of, for example, let's say a pain score that's deteriorating. So they're being monitored game by game, and they're being assessed with Achilles pain scores. They're being assessed with activities that they can or can't do, and things like hop height, hop length, calf raise, endurances can all decrease. Now, you will all have your own ways to assess how you like to, determine whether the Achilles is deteriorating or not, or indeed any other muscle in the body. Is the tendon stiffer? Do they have a reduction in their ankle range of motion? Swelling, I think, of course, is a significant finding, especially acute swelling after what was a normal tendon. And of course, rarely, thankfully, do we see ruptures on the background in elite sport. But of course, when it does happen, it's a significant event and almost always needs surgery. Patients will have often had MRI, ultrasound, or UTC scanning, which is the lovely images we just saw previously. And of course, they will have had, almost certainly at the level that we're dealing with, a failure of conservative management. So they'll have absolutely had a proper loading program. They'll have had their mechanics checked and their orthotics supplied, etc. And indeed, some of them are even going through shockwave therapy, which I think is an absolute no-brainer. And certainly in the amateur game, it's something I would absolutely expect players to have had done, and even in the elite sport as well, if they have time, if they can go through shockwave, that would help. And of course, some of them have even had, for example, a high volume stripping injection done previously that has potentially failed. So what sort of pathologies are we looking at? Well, one of the things that is talked about a lot these days is what's called the plantaris tendon. Now, the plantaris tendon is medial to the Achilles, and it can give a similar, it can give a pain that is very typical of Achilles tendinopathy, mid-substance pain, often more medial. And you can see here in this MRI scan, there is a subtle but definite difference in swelling and the high signal around the plantaris tendon on the one that is circled rather than the one on the left-hand side. So there's clearly something there. So you can get intersubstance tears or tendinopathy. So here you can see an intersubstance tear on the background of what is, I think, a fusiform swelling of the tendon. So it's clearly something that is going to cause pain. And of course, you can get more of an isolated acute inflammatory change around the tendon. So on the picture on the left, you can see what effectively is probably a normal tendon, but possibly a little bit of signal change. But what there is significant circumferential high signal, which is indicative of paratendinitis. And of course, the image on the right, you have the fat pad just anterior to the Achilles tendon behind the tibio-talar calcaneal joint, which is known as Kager's fat pad, and it has proprioceptive functions similar to the fat pad in the knee, I suppose, but this area can get significantly inflamed and painful, and it often, but almost always goes hand in hand with a significant paratendinitis as well. So multiple pathologies. Of course, when you're doing imaging or injections, you can get beautiful pictures here. Now, I don't do these at all. In fact, I find it difficult to read these. As you all know, ultrasound is a very difficult technique to master, and it's certainly done in the UK by our radiology colleagues who will do all the interventions. But what they can see is Doppler flow. They can check for neovascularization. And of course, the image on the bottom right here, number 3, you can see a beautiful description of what is a high volume injection, the needle going in vertically and stripping the paratenon away from the Achilles tendon. So there's lots of ways to treat these, but we do them. They're all done by the interventional radiologists in my unit. So the Achilles tendon injections that we do, this is something that you will all be almost certainly very familiar with. These aren't done by me, but patients will have often had them before they come and see me. So one of the things that I like to discuss with the radiologist is the tendon radiologically normal or not? If it's not normal, then basically we don't use steroid. I think it's too much of a risk. The risk of rupture of an Achilles is anywhere up to 2% or possibly even higher than that. And it's just something that you do not need in an elite athlete. So I would absolutely advise against that. So if they have a degenerate tendon, if they have an edematous tendon, if they have multifocal change, then you can often do a high volume stripping injection with local anesthesia and also hyaluronic acid. But of course, if they have a localized problem in the tendon, such as a linear tear or a very localized area of degenerate change, you can try a PRP or PRGF injection to see if that's going to provide a very localized healing response. That's something that I would be much happier to do, of course, than anything like a steroid. If they have a normal tendon, theoretically, you can think about using steroid. But if I'm honest, we don't really use it very much at all. We use a lot more local anesthesia and also hyaluronic acid injections to try and strip tendon, especially in paratendinopathy. Of course, around plantaris, it has a very good effect. So what is the plantaris tendon? Well, if you're familiar with it, then you will know that it originates high in the calf, and it often originates even more proximal to this, but it goes medial in the calf muscle complex and then tends to converge on the Achilles tendon as it goes distally. So this different course of anatomy almost always will then, it will make you think, well, actually, it must have a different effect, a different motion, a different action than the Achilles tendon itself. But it runs very close down to the medial aspect of the Achilles tendon. As you can see here, it's coming down medially to this Achilles tendon. We're looking at the posterior medial border of the ankle here. So it's more stiff and it's stronger than the Achilles tendon. Here you can see a force elongation graph where basically it takes a much higher force to effectively rupture the plantaris tendon, but it doesn't actually stretch as much effectively. So the plantaris tendon also has a variable insertion point. Commonest is probably just medial and anterior to the Achilles tendon itself. So what we have seen in some studies that if insertion is on the Achilles tendon itself rather than on the calcaneus, it's more of a synergistic muscle than it could be otherwise, so it's possibly less likely to cause pain. And if it inserts more distally around the calcaneus, then that friction or pressure increases between the Achilles tendon and the plantaris, which is obviously due to the differential motion and theoretically, but not definitely a source of pain. So what are the options? Well, when we're looking at the Achilles tendon, there's multiple options. But effectively, let's say we're dealing with a high level athlete, we're looking for something that is going to get them back relatively quickly and of course be as lowest risk as possible. So you can do open or of course tendonoscopic Achilles paratenon stripping. You can excise the plantaris tendon both via open and endoscopic methods. And there has been a lot of people talking about doing multiple tenotomies, effectively stab incisions around the Achilles tendon to try and promote some inflammatory response. This is almost certainly better than doing what's called a cord decompression or an excision of the Achilles tendon, which I do a lot in, of course, non-athletes and people who haven't got a huge demand on their Achilles tendon, because there is definitely a weakening effect here, and the biggest worry I would have is obviously risk of rupture. And if we're dealing with insertional pathology, you've all probably heard of a Haglund deformity, which can be excised, or of course you can remove the footprint of the Achilles tendon of the calcaneus, debride it and reattach it, which is something I have to say I've never done on a first-class elite athlete yet, and it's not something that I really want to do because it would worry me about the stresses on that. But of course, what if needs must, and then I would go down that road. So what exactly is stripping of the tendon? Well, is the neovessel a sign of the pain? Here you can see some lovely pictures of neovascularization. But of course, there are some publications out there which really show that there may not be any correlation between neovascularization and pain. So we have to be a bit careful in analyzing these ultrasounds. But effectively, stripping is really a very aggressive high volume injection. You're removing adhesions, you're denervating the tendon, which is probably the more important thing. And you're doing this in an environment where you're maintaining structural integrity, and therefore you can accelerate strengthening and rehab and hopefully have a very short time out of any activities. So the ways to do this, of course, you can do open Achilles stripping and plantaris excision. And this, I think, is a lovely picture of a young military recruit that I treated many years ago who had severe bilateral Achilles pain with the plantaris basically adherent completely to the Achilles. But of course, in a cord decompression, which basically means you cut the Achilles open and scoop out the degenerate pieces, there's the risk of rupture I would worry about for sure. So in this patient, we simply did a stripping and a plantaris excision, and he actually did very well, which was lovely. So other ways to do this, picture on the left is an open plantaris excision and Achilles stripping. And one of the things I want you to look at on this picture on the left is the differential color between what is the plantaris tendon, which is actually massive, and the Achilles tendon itself. This was somebody who had severe pain for about 5 years, and we ended up removing the plantaris, and he did well. The picture on the right is a minimally invasive way of taking the plantaris tendon out, which is what I favor. And this is something that is quick to rehabilitate from. And at the bottom, you can see minimally invasive or tendoscopic ways to effectively strip the Achilles tendon and also remove the plantaris tendon. So there's many ways to do this, but ultimately it's a fairly low morbidity option to try and treat what is medial Achilles pain. So the post-op period, they often go into a soft bandage and an air cast boot, and I would be fairly conservative with my athletes, especially in the first 2 weeks, because all I want to do is get the wound to heal. Once that heals, then I'm happy. You give them gentle ankle range of motion for 5 days, after 5 days, and they can start to mobilize out of the boot, and really after 6 weeks, maximize strengthening for a return to play. But when you look at the literature, you're talking about 2 to 3 months or even longer before they're very comfortable getting back to full activities. So it does take time. there's a low risk of infection and surgical complications, thankfully, and you can monitor these patients with UTC scanning or even standard scanning to look at changes in the neovascularization, to look at changes in the localized inflammatory response around, for example, the medial aspect of the Achilles tendon, which you can see here has improved from the picture on the left to the picture on the right with the loss of the red changes. So other ways are, for example, proximal medial gastrocnemius release, which you may well have heard of. This is not something that I would ever do or have ever done. Well, I would do it if necessary, but I've never done it in an athlete yet, because I think it's very specifically for those patients who have got severe or significant gastrocnemius contracture with tendinopathy. And the way the athlete's conditioned now, you rarely will see that, but it has got some good results in patients with Achilles tendinopathy. With good improvements in the VISA score and also the American orthopedic scores as well. So when we're dealing with insertional Achilles tendinopathy, we'll just go through this here at the end. There's multiple pathologies, and I never like the term insertional Achilles tendinopathy because you're dealing with patients who have got, for example, a Haglund, which is the old-fashioned term for the bony prominence. You can see here on the top left. On the bottom left, this is actually the same patient who has got edematous change around the calcaneus, but interestingly has got intrinsic change in the Achilles and also ossification at the insertion. So there's multiple pathologies here. And also, if you look closely, there's also a retrocalcaneal bursopathy as well. Picture on the right here is a slightly more advanced version of the one on the left. So there's multiple pathologies here as well. So simplest things, avoid surgery if you can, because unless you can do a very simple procedure, you're talking about a lengthy rehabilitation period. So try and decompress the tendon using heel raises, wearing soft back shoes, and even different football boot designs, for example. You want to correct any hindfoot position because there's definitely a link between hindfoot malalignment and insertional pain. And of course, if you try any stretches, then the only thing is with eccentric loading, you have to be a little bit careful because you can actually irritate the insertion quite a lot. So sometimes floor level eccentric loading is slightly better. So here's a picture of effectively a minimally invasive Haglund incision, which is something that can be done very, very easily with a quick rehabilitation turnaround. You've got a patient with a bump or a large bump in the back of the calcaneus, and also soft tissue swelling here around the Achilles tendon as well. You go in with a small hemostat to try and isolate the soft tissue over the top of the lump itself. So we're dealing with very minimally invasive scars. This is a shaver that's gone in to try and isolate the top of the bone here, and we're going to shave away this top half of the bone. Here you can see the shaver in operation to remove the bone, and here's the finished product. So we're dealing with a patient that has never had the Achilles insertion removed. We've had the bump taken off in front of it to try and decompress the Achilles insertion. This is in contrast to the picture down here on the right, which basically is an open Achilles insertional reconstruction, where basically you actually chisel off the entire footprint of the Achilles, you lift it off, and then you reattach it with anchors, which is a much bigger and more involved prospect for the athlete, which is not something that I would routinely recommend. But of course, when needs must, it might need to be done. So in elite sport, what I think is really important is that we all communicate very well. Myself, the medical teams, the athletes, the physiotherapists, etc., communicate well to know exactly what the patient needs, what the patient wants. We have an understanding of that particular individual's demands on their body, and also what will their timelines be for return to play if any intervention is going to be considered, because everybody's different. Everybody reacts differently to surgery. But I think from my point of view, and also when I'm speaking to club doctors or club physios, what can we do to allow play and not risk deterioration? And what that means really is, can we put things on hold? Is there a better time in the season when the patient or the player or the athlete can have their intervention done without risking their own tendon, their own body, but also allowing them to get through a season, for example. And the ways that they can do this is to make sure they're in the physical peak of fitness. And, you know, as you all know, they're quite remarkable, some of the athletes that we deal with who have got the most amazing ability to maintain strength, more importantly, but also general fitness. And we also try and plan the treatment and the surgery with any other commitments that they may have. For example, obviously their sporting commitments, but obviously other things in life, commercial commitments, etc. So to summarize, I think what we need to do is we need to localize the pathology, and we need to localize the nature of the lesion, whether it's a particular split in the tendon, a tear in the tendon, whether it's a localized area of high signal, or whether it's a much more involved injury of the tendon itself. I think injections can be used with success, but with very specific indications. And I would urge you to try and rationalize the injections that you're going to use. Don't just sort of blanket say, right, we're going to inject the tendon. I would try and come up with a reason exactly why you're going to use a high volume stripping injection. Are you going to use steroid? If you are, be careful and make sure there are specific indications for that. Because I would say steroids are generally not advised around the Achilles tendon. I think surgery on the whole, the minimally invasive surgery especially, is low risk and tolerable with quick recoveries. But of course, one must choose the correct operation for that patient and that tendon. And if it needs something bigger, then so be it. But if major reconstructive surgery is needed, then that needs to be really discussed at great length with everybody, so that everybody knows exactly what the demands are. But I think by far, and I haven't really gone into this in much detail at all, but I think by far the biggest and the most important part of the rehab pre and post surgery is appropriate loading. And basically, I have so much respect for the medical teams and the therapists and strength and conditioners, because these are the people who, in my opinion, are really pushing the patient to the limits of their boundaries and safely at the same time. Thank you very much.